do want to thank Perfusion.com and Ty for that lovely welcome and allowing me to speak on a can everyone hear me? Pull it down for the short person, right? Is that better? Yeah? Yeah? Okay. On a topic that I've become quite passionate about, Autotransfusion and Obstetrics. And I also want to thank Perfusion.com for Clint Studer and his talk. I'm sure the next one's going to be great, but I took away some really great pearls of wisdom from his talk last night, and I absolutely agree, as I'm sure all of you do, that we all went into healthcare to make a difference, right? To make a positive impact on patients' lives, to make a difference. So I would suggest to you that there are ways to make a difference in other arenas rather than cardiac surgery. So, and you have an opportunity to expand your scope of practice perhaps, especially in hospitals where caseloads are down. So in cardiac surgery, you do make a difference. Every single one of you here in this room and joining us via webcast, get up every day, put on scrubs, go in that OR and save a life. In obstetrics, you have a unique opportunity to save 2 lives. When I started doing research on blood loss and maternal death rates, I was appalled. There are nearly 4 million births registered in the United States, and that was in 2014. Those numbers are on the increase. 700 to 800 women die every year during pregnancy or shortly after birth. Those are staggering numbers. You know, we pride ourselves in the U.S. for having one of the best healthcare systems in the world. So the fact that our rate of maternal mortality in the U.S. has more than doubled in the past few decades is really scary. There was a ranking done in 2014. There are 46 countries in the world that have lower maternal death rates than the U.S. We are ranked 47th in maternal death rates. So for those of you that listened to Deb Adams yesterday morning, we don't know. We need to dig deeper to find out what all those reasons are. There are certainly a myriad of reasons, but I would suggest to you that blood loss is one of them. From 1999 to 2002, the rate of maternal death was 9.8 per 100,000 live births. It is now today 23 per 100,000. Does that number startle anyone else? Because it certainly startled me. You know, we assume that we're doing a very good job, and we try to do a very good job, but there's always room for improvement, room to make a difference. This statement in the blue box was from, if I can get my pointer to work, it worked a minute ago, guys, sorry. But we need to uncover the cause of maternal mortality. We need aggressive interventions to keep women healthy before they get pregnant. So a lot of these women present for delivery, whether it's C-section or it's a normal delivery, but they present anemic. So that provides a problem. We need better care during and after pregnancy, and we need to make better efforts to save women from preventable death. In the year 2018, maternal deaths are still a significant risk. Women are still dying, mostly from postpartum hemorrhage. If the hemorrhage does not result in death, we have a weak mother who's less able to care for her baby that she just brought home. We're really gaining momentum and attention in this area. The UK was kind of the brink of that, but some states in the US now, in particular California, Pennsylvania, and New York, and including the Joint Commission, have developed a task force and guidelines to improve care. And if you want to delve a little deeper into that, there is a website. The California Maternal Quality Care Consortium has a website that you can go to and learn more about that. So there are many definitions of obstetric hemorrhage, and I'll go over like the top 3, basically. Obstetric hemorrhage, though, poses a significant risk, obviously, to maternal health. It accounts for 30% of all maternal deaths worldwide. It's a big number. So What that amounts to is 150,000 women worldwide die each year because of obstetric hemorrhage. It's a big number. It's among the top 4 causes of maternal death. So I'd like to credit Dr. Waters for this slide, for simplifying this whole thing for me and sort of bringing it together and making it mesh. The biggest and best definitions of obstetric hemorrhage are transfusion of more than 10 units in 24 hours, or transfusion of 4 units in 1 hour with the continued anticipation or need for support, and a replacement of 50% of the total blood volume within 3 hours. Top 2 high-risk pregnancies that result usually in obstetric hemorrhage are 2 types of placental abruption. So just a brief definition. It's placenta accreta typically, or placenta previa. So in accreta, the blood vessels and placental parts grow too deeply into the uterine wall, and the placenta does not detach from the uterine wall typically after childbirth. In previa, the placenta partially or wholly blocks the neck of the uterus, interfering with delivery. Both can cause obstetric hemorrhage. So let's talk about some costs. These women get transfusions, which have, of course, are associated with a lot of risk, but they're also costly. Most hospitals pay, just to acquire a unit of blood, $200. The ancillary costs, however, end up being as much as $2,400. Medicare pays $180 for a unit. So we're upside down on costs on blood transfusions for sure. The Department of Health and Human Services issued a pretty strong statement that we are excessively and inappropriately transfusing blood in the US. And of course there's risks, but there's also costs to that. So we're placing a huge financial burden on our healthcare system by inappropriately and often over-transfusing packed red cells. So I would suggest to you that autotransfusion is a viable and real insurance policy. Should unexpected blood loss occur, cell salvage is cost effective. There's a lot of data to prove that. Excuse me. I've cited 4 references, but there's a whole lot more out there that show that it poses less risk than allogeneic transfusion, even in the obstetric suite, and it costs far less. Of course, the more units you produce, the lower the cost. And obviously, the average cost for a setup, regardless of whose system you use, is less than a banked unit. So why in obstetrics? Well, because we want to make a difference, and we can make a difference. Autotransfusion is a safe adjunct. There is frequently sufficient blood loss to warrant processing. So there's a lot of evidence out there about obstetric hemorrhage, rapid high blood loss, and autotransfusion. But some of these devices are also a good insurance policy as far as having, in a discontinuous system, a small bowl size. Sorry. So a standby setup can be used. If there's enough to process, then you can choose a bowl size, insert it very quickly, and then process as necessary. So AABB and a large body of literature does recommend a double suction setup to minimize aspiration of amniotic fluid. Washing of surgical sponges can yield a lot of blood, more than you might expect. And they also recommend the use of a leukoreduction filter. That's not always used. They recommend and suggest a leukoreduction filter to remove fetal squamous cells, bacteria, and tumor cells. So particularly in C-sections versus a natural delivery, there's much more significant blood loss. The mother, regardless, feels the same. With a lot of blood loss, you get what you would expect. You're anemic, you're weak, you're lethargic. It's very depressing because they can't do what they would like to be able to do when they come home. It makes it really difficult to care for their babies. So, and as you all know, blood transfusions are also risky, and they carry long-term immunomodulatory effects. So if the woman plans to be pregnant again, then we've set her up for perhaps a rather nasty incident. So this statement in the purple box comes from an entire body. It's from a Shotuck study, and they found that the maternal death rate is 4 times the maternal death rate associated with vaginal delivery in a C-section. So why do we not use autotransfusion routinely in obstetrics? Well, there's a fear. There's been a historic fear of an amniotic fluid embolism. We worry about maternal allo immunization. It's really difficult to staff the OB suite. It's also been considered off-label. So in the past, most of the devices do not have an indication for use, excuse me, with their 510K for their autotransfusion devices. The XTRA does. So that is in our indications for use in our 510K. So, and I can't speak to other manufacturers, but I would guess that a lot of them are as well in their newer devices. So the technology's better than it used to be. The risk of cell salvage in the obstetric population parallels those in the general population. It is no more risky as long as we do things right. The level of fetal squamous cells in salvage blood is comparable to those in the maternal venous blood at the time of the placental separation. So that would suggest that it's not nearly as risky as we used to think. There have been no definite cases of amniotic fluid embolism reported, and it appears unlikely that there ever will be. And it is cost effective, especially in patients with a predictably high rate of transfusion. So a little bit more about the amniotic fluid embolism. Why do we worry so much about it? Well, for obvious reasons. It can result in hypotension, pulmonary edema, coagulopathies, including DIC and cardiopulmonary arrest. It is also a bit of an enigma, a bit of a mystery. There's no definitive causative agent. It may relate to biochemical components, or it may relate to particulate matter. So it depends on which study, which paper you read, where they put the emphasis, but the bottom line is it could be either one. Samples of salvaged blood after washing have been found, and this is another Waters article, but have been found to show significant reduction in amniotic fluid, so significant that it's comparable or lower than that of the maternal blood. So is amniotic fluid embolism a really and truly embolic event? Well, many people think not, including Dr. Waters and Dr. Clark et al. In this study. They feel like it's a non-immune anaphylaxis. So database analysis found 41% of these patients who had a reaction had an allergic history. So a lot of these experts also feel like we've misnamed it, that it's not really ever been an amniotic fluid embolism. It's been an anaphylactoid response. They feel it should be renamed anaphylactoid syndrome of pregnancy. So large bodies of data suggest strongly that if we wash the blood with an autotransfusion device and we use a leukoreduction filter, that we have mitigated the risks quite significantly. Tissue factor really is what is of the most concern. So we take caution. We wash with more blood, or with more saline, 6 to 8 times the bowl size, so much as we would do in an orthopedic case. There's also, in our device, there's something called better quality wash. So that's basically a stopping and starting of the wash cycle. It uses more saline, and it also allows everything to come back into solution so that we can ramp up and allow the red cells to push more of the amniotic fluid or the plasma out into the waste bag. Bernstein found, and look at the date on that study, 1997. Bernstein found that tissue factor activity is near 0 after it's washed, which suggests to us that the blood is safe, right? So why a leukoreduction filter? And as I said before, we may not wash off everything. So the leukoreduction filters do have the ability to remove fetal squamous cells, a large bacterial count, and tumor cells. And yes, these filters are slow. And I will tell you that in an emergent situation, I've seen enough obstetric cases where they didn't use it and not have a problem that they suggest that you use it, but it may not be 100% necessary. So the advantage, you know, I'd get to another advantage of my equipment, right? We do have an emergency protocol. So we can return blood washed in approximately 3 minutes. We compromise crit, of course, but at that point, hematocrit is the least of the concern. So what we don't compromise is wash quality. And we do have indicators on the device to add that extra layer of safety. So we can tell you essentially whether that product is clean or not clean. So just, I'm not going to go through a lot of studies, but this was not a large study, obviously 20 women, but it was a good solid study. They used autotransfusion in 15 of these women. Not one of those women required a transfusion. There was no incidence of amniotic fluid embolism, no hypotension, and no other adverse event. And I will tell you in this study, they did not use the leukoreduction filter. So there's a lot of data that shows that salvage blood can be used to minimize allogeneic transfusions, especially in cesarean hysterectomies, placenta accretas, any obstetric, and in obstetric hemorrhage. This was a case that I was actually in, and this triggered, I suppose it really, really triggered and my passion for this, and it made it real to me. This was at McGee in Pittsburgh, and they had just gotten their extra devices, so they, of course, were not comfortable running them. And thank heavens, there's a Hampton Inn right across the street. The lady presented to the emergency room. I got the call and ran over, met him in the ER. They were transporting the lady up. She was bleeding out. She was a Jehovah's Witness patient. She also had sickle cell disease. Her pre-op crit was 22. She was losing blood fast. So got her in there, and you know the other thing about obstetrics is that the patient's awake, right? Keep in mind, they're not asleep. They're awake, and they're in pain, and they're panicked, and it's just a total. And Dad's in the room. So, you know, it's really a high-stress situation. So we were able to return 125 cc's, which may not seem like a lot, but when you present with a 22 crit, if you can give back 125 cc's of a 28 crit, and it's a clean product, you've made a difference. You've absolutely made a difference. Mother survived, baby survived, and they are doing well to this day. So, you know, that had a lot of impact on me. It really, really did. And we all walked out of that room and high-fived and felt like we made a difference. So, autotransfusion in obstetrics does not appear to increase the rate of infection, DIC, or amniotic fluid embolism. It is currently recommended by a lot of people in unexpected major hemorrhage or in cases of where you do expect a major hemorrhage, such as placenta accreta or previa. It may also decrease the risk of infectious and non-infectious complications of allogeneic blood transfusion and may even decrease mortality. And I can guarantee you in that case, we decrease mortality. Recommended by all of these people for very good reason. It's because we have a huge void of evidence to support contraindication of blood recovery in obstetrics and gynecology. So it is one significant step. It's not every step. It doesn't answer our huge and growing problem of maternal death in the US, but it is one way in the operating room that we can make a difference. Thank you. Any questions?